Anytime we have a bone connected to a bone, then we have a joint. Some joints are immovable. They allow for zero range of motion, while other joints are quite movable. Some of the tissues that are associated with joints would include ligaments that attach bone to bone, tendons that attach muscles to bones, cartilage, which serves as both a connection and a cushion. We also have in some joints a joint capsule that is fluid filled. And also at some joints we have structures called bursa, which minimize friction at the moving joints. So this is a brief rundown of the joints of the human body. And I have tried to keep it as concise as possible because I know that we're pressed for time. So let's move on to slide number 2 and talk about the types of joints. When there are two or more bones, but at some point in development, the bones fuse together and ossify to form just one bone, that is called a bony joint or a synostosis. The example shown here in the picture of a synostosis, the ilium, the ischium, and the pubic bone. Well, that's three different bones, but they fuse together to form just one hip bone. Another example of a synostosis are the two frontal bones, which are present in the fetus, but fuse together to form just one frontal bone after birth. Another example is the epiphyseal plates, which separate the ends of a long bone from the shaft. Well, that is cartilage that forms the epiphyseal plate. The cartilage is replaced by bone. And so at about age 20, the epiphyseal plates are gone, and all you have is just one unified bone. So those are examples of synostoses or bony joints. Number 2, the fibrous joint or the synarthrosis. There are three types of these. The one shown in the picture is called a suture joint. The bones of the cranium are held together by sutures. Those are very short and tight collagen fibers that hold the bones together. There is no range of motion between those bones, obviously. Also, the tooth in the alveolus, the periodontal ligament, which holds the teeth in the maxilla or in the mandible, that is called a gomphosis. It is a type of fibrous joint. Also, at the distal radioulnar joint, right at the wrist, there is no motion between those two bones. The collagen fibers or the ligaments are very tight, and so if there's any range of motion at all, it is minimal. So those are three types of synarthroses or fibrous joints. When the connecting material is cartilage, then we have a cartilaginous joint or an amphiarthrosis. Examples of this would be if the cartilage is hyaline cartilage, then we have what is called a synchondrosis. Hyaline cartilage connects the ribs to the sternum, so that's an example of a synchondrosis. Also, when the cartilage is fibrocartilage, then we call those joints a symphysis. The best example of a symphysis joint is the pubic symphysis, which joins the right and left pubic bones. The example shown in the picture are the intervertebral disc, that is fibrocartilage that connects the bones to each other. The fourth type of joint is a synovial joint. Synovial joints allow for range of motion. So we have a joint capsule, which is filled with synovial fluid to minimize friction between the moving bones. So we'll spend the rest of this slideshow discussing the synovial joints and the various structures found within them. Next slide, please. Well, we have to have tissues to hold things together. Anytime we have moving parts, things can get dislocated and separated from each other. So we have a variety of tissues that are there to hold joints together. Also, anytime we have moving parts, we have the potential for friction. So that friction is minimized by the presence of a joint capsule and the synovial fluid, which is contained in the joint capsule. So the temporomandibular joint, the condylar process of the mandible fits into the mandibular fossa of the temporal bone. And we have to hold that in place because the jaw is known for moving up and down, left and right, front and back. So the jaw can move in a variety of planes. Oftentimes, the most effective stabilizers of a joint are the muscles that attach to the bones. So in the image on the left, we have the four muscles of mastication. Mastication means chewing. The prime mover of mastication is the temporalis muscle, a synergist muscle that goes with that to help in the process of chewing is the masseter. And then in the second illustration there, we see the medial and lateral pterygoids, which help to move the jaw left, right, front, and back. So those muscles and their tendons also stabilize the temporomandibular joint so that the bones are held together. Well, we also have ligaments. There are actually three ligaments. So look at the illustration on the right. There is the temporomandibular ligament that is also and usually called the lateral ligament of the jaw, connecting the styloid process of the temporal bone to the angle of the mandible, that is the stylomandibular ligament, and not shown here because it is deep to these two, the sphenomandibular ligament. So that's the general structure of the temporomandibular joint. You may have heard of people who have temporomandibular joint syndrome. Uh, they have pain associated with their jaw and also problems keeping the bones together. So TMJ is actually a pretty common malady amongst people. Okay, let's move on to the next synovial joint. Well, when we were looking at the scapula and you had a look at the glenoid fossa, the one thing that you should have noticed is that the glenoid fossa is very shallow. So this is a ball and socket type of joint, which allows for motion in all three planes of space, up, down, front, back, left, and right. So here we have a ball, the head of the humerus, which has to stay situated inside the socket, which is the glenoid fossa. Well, the glenoid fossa is very shallow, so it is a real problem to try to keep that ball in place. Well, these are the structures which accomplish that. So once again, a lot of joint stability is offered by the muscles that attach to the bones involved. So we have four rotator cuff muscles. Three of them are shown in the illustration on the left. The supraspinatus muscle, the infraspinatus, and the teres minor. Coming from the front of the scapula, so it's not shown here, would be the subscapularis muscle. The tendons of all four of those muscles insert on the head of the humerus to hold the ball in the socket. So the much of the joint stability is simply offered by the attachment of those muscles. In the middle image, I'm showing there the joint capsule that contains the synovial fluid for minimizing friction, as the ball moves inside the socket. We also have a variety of ligaments. They are named for the bones that they connect. So you can see the coracoacromial ligament, the acromioclavicular ligament. So these are ligaments, which are collagen fibers that attach bone to bone. Another muscle that contributes to the stability of the glenohumeral joint is the biceps brachii. It's not labeled there, but the tendon of the biceps brachii is there, cut off. It also contributes to the stability of the joint. Now, when we look deeper inside the joint, we're going to look at the things that hold the ball in the socket so that it doesn't come out in spite of all of these tissues that we have. Well, the glenoid fossa has a cartilaginous rim around it to give to it additional depth. So when you just look at the bone of the scapula, the glenoid fossa is very shallow. But when you add that fibrocartilage rim, which is called the glenoid labrum, then it has greater depth so that the ball is not so likely to come out of the socket. Also, inside the joint capsule, there are 3 additional ligaments which attach the glenoid fossa to the head of the humerus. They are called the glenohumeral ligaments. So in the view on the right, you can see that there is a superior and a middle and an inferior glenohumeral ligament inside the joint capsule to help hold the ball in the socket. An additional structure which is seen here, there are actually 4 structures at the glenohumeral joint that are called bursa. A bursa is simply a sac of synovial fluid which sits between a bone and a tendon. A tendon will move. A bone doesn't move. If the tendon moves and glides over the surface of the bone, that's going to create friction. So the bursa are there to kind of pad, cushion, and minimize friction where tendons run over bones and therefore may rub against them. So we have bursa located at all of the synovial joints to help reduce the problem of friction. So looking into the glenoid fossa there, you can see the muscles, the tendons, the glenoid labrum, and all of the structures that are there to stabilize and help hold the ball in the socket. Where the humerus joins to the radius and the ulna. Well, this is the elbow joint. It is a hinge joint allowing for motion only in the front and back planes so we can flex and extend the elbow, and that's about all it offers. Remember that the head of the radius has to glide over the smooth condyle of the humerus when the arm is flexed. The condyle of the humerus there on the radial side is called the capitulum. Also on the ulnar side, that is the trochlear notch of the ulna, which has to glide over the trochlea of the humerus when the arm is flexed and extended. So we do have motion, therefore we need to minimize friction. So we have a joint capsule, which is filled with synovial fluid. There are 3 principal ligaments holding these bones together. On the lateral side, attaching the lateral epicondyle of the humerus to the head of the radius, that is the radial collateral ligament. On the medial side, attaching the medial epicondyle of the humerus to the ulna, that is the ulnar collateral ligament, and then running across from the radius to the ulna, that is the annular ligament. So those are the three principal ligaments involved in holding the elbow joint together. But as it is with other joints, the muscles that are attaching at those locations are the principal stabilizers of the joint. In the image on the right, the same structures are shown again: the joint capsule, the annular ligament, the tendon of the biceps brachii attaching at the radial tuberosity is a big time stabilizer. But the reason I included the image on the right is because it shows the olecranon bursa. Remember that the tendon of the triceps brachii on the back of the arm has to wrap around the point of the elbow right there. When a muscle contracts, its tendon will move. Well, that's going to rub against the bone there, so we have to have a cushion and we have to have something to minimize friction. So the olecranon bursa, which is a fluid-filled sac, to cushion and minimize friction there at the point of the elbow. The reason I pointed it out is because olecranon bursitis is very common. When that bursa becomes inflamed, it will swell up like a golf ball. Okay, that's a pretty concise look at the elbow joint, so let's move on. Well, here we have another ball and socket type of joint, which allows for motion in three different planes, so we can go front, back, left, right, up, and down, courtesy of the ball in a socket type of arrangement. So anytime we have a ball and socket joint, such as the shoulder or the hip, we have lots of range of motion, but we also have a high risk of dislocation. So we have a great number of things situated to hold the ball in the socket. Now, the ball is the head of the femur. The socket is called the acetabulum of the hip. So in the illustration on the left, here are a few. I would guess that there probably are about 30 muscles that play into stabilizing the hip joint. I just wanted to show these on the backside. These muscles are called the lateral rotators. They are called that because they insert on the head of the femur to rotate it. So the femur can rotate, ball can rotate within the socket. So these lateral rotators not only rotate the ball within the socket, they hold the ball in the socket. So we have, like I said, there's probably about 30 muscles that are involved in holding the hip joint together, and these are just a few of them on the back side. So the muscles that I can see there, the one up top there, that is the gluteus minimus. The lateral rotators are the piriformis, the gemellus superior, obturator internus, inferior gemellus, and the quadratus femoris. On the left side, that's the big gluteus maximus, and along with it, the gluteus medius. So these are muscles that move the leg, but also muscles which stabilize the joint. Okay, in the illustration on the right are the structures that are involved that are non-muscular. The acetabulum is like the glenoid fossa of the scapula. It's very shallow. So we make it deeper by adding a rim of fibrocartilage. That is called the acetabular labrum. It gives greater depth to the socket, so the ball is not so likely to come out. We have four principal ligaments that are involved in holding the ball in the socket. Number one, the ligament of the head of the femur. It attaches the head of the femur directly to the wall of the acetabulum. There is also an iliofemoral, an ischiofemoral, and a pubofemoral ligament. which attaches the femur to the hip bone to prevent the dislocation of the head of the femur from the acetabulum. So those are the principal structures of the coxal joint. I hope you enjoyed it. Okay, here we are where the femur articulates with the tibia to form the knee joint. Well, we have another hinge joint here allowing motion only in one plane, the front and back, as the knee extends or as it flexes. The muscles involved here, the big quadriceps muscles coming from above, their tendon, which encloses the patella or the kneecap, that tendon is going to insert at the tibial tuberosity, so it adds stability to the front of the knee. We also have muscles on the backside. Those are called the hamstring muscles to give us stability on the backside. Since it is a hinge joint and we have motion, then we have potential friction. So it does have a joint capsule, and inside the capsule is synovial fluid. Also, we have two pads of fibrocartilage to kind of cushion the two bones coming together, the femur on top of the tibia. Remember, those are weight-bearing bones, so we're not just talking about motion like we would have at the elbow. In the case of the knee, we have the problem of weight bearing. So here we have the two pads of fibrocartilage called the medial and lateral meniscus. So those are cartilaginous cushions to connect and also to pad between the bones involved. We have the anterior and posterior cruciate ligaments inside the joint capsule. And then outside the joint capsule, we have the lateral collateral and the medial collateral ligaments to hold the bones together. Since we do have a lot of activity at this joint, then we have, I think the number is 23 bursa that can be found at the knee joint. So look at the illustration on the right. There's a listing of maybe 5 or 6 of those. The suprapatellar, the prepatellar, the deep infrapatellar, the superficial infrapatellar, and also on the backside, the popliteal bursa, the subartorial bursa. So at the knee joint, we have several little sacs of synovial fluid to kind of minimize the friction where the tendons rub over the bones, etc., etc. So this is a concise look at the knee joint and the structures involved there. I hope you enjoyed it, and I hope that little sister enjoys hearing about it when you tell her. Well, the bones involved at the ankle joint include the weight-bearing bone, the tibia, and also its friend, the fibula, and also the 7 tarsal bones that we have talked about. The weight of the body comes down the tibia and is distributed directly down upon the talus, which then sits right on top of the calcaneus. So that is the axis of gravity there. The other bones of the ankle include the navicular, the cuneiform 1, 2, and 3, and also the cuboid. Well, all of those bones are held together by individual ligaments, and the ligaments are named according to the bones that they connect. So we have tibiofibular, talofibular, and we have calcaneofibular, we have talofibular. These are the names of the ligaments, and you can see from the illustrations here that all of the bones connect to each other by way of these ligaments, and you just name them according to the bones that are connected. Also, structures that are involved in stabilizing the joint would include the calcaneal tendon. That is the big tendon that comes down from the calf muscle, oftentimes called the Achilles tendon. The plantar fascia, which is just under the skin on the sole of the foot. And also on the front side, you have the tibialis anterior muscle. On the lateral aspect, you have the fibularis longus, the fibularis brevis, and the fibularis tertius. So these are muscles that stabilize and hold the ankle joint, all the same since we are bearing weight on the ankle. Anytime we make a wrong turn, the ankle is at risk of turning over, and if that happens, it will strain those ligaments and you've got a sprained ankle. So that is no fun at all. Okay, so be familiar with these structures that make up the ankle joint, and you should do fine. Okay, these are a few terms that reference motion at joints that you should be familiar with. If we flex one bone relative to another, then what we do is decrease the joint angle between the two bones. Say, for instance, we have the arm fully extended. Well, that angle is called 180 degrees. It's just straight out. If you flex the arm, then you decrease the joint angle. You come from 180 to 90, and then the arms will flex even beyond 90 degrees. Extension is just the opposite. That would be to increase the joint angle between the two bones. So when you extend the arm, you take the flexed arm and you straighten it out again. That increases the joint angle back to 180 degrees. Abduction means to move away from the midline. So if you take the elbows and raise them up such that the upper arm is parallel to the shoulders, then you have abducted the arms. They have moved out away from the midline. Adduction is just the opposite. That means to bring back toward the midline. So if the legs are spread out completely and you bring them back together again so that the knees are together and the ankles are together, then you have adducted the leg to bring it back toward the midline. Elevation means to raise up. Depression means to allow to sink down. We can elevate the shoulders just by shrugging the shoulders. That's called elevation. When the shoulders come back down to their normal position, that is called depression. To protract and to retract, well, that would mean to jut forward or to pull back. So we can protract, say, the jawbone. You can jut your chin out forward, or you can pull your chin back to its normal position. So that is protraction and retraction of the mandible. Supination and pronation are referring usually to the lower arm and hand. So if we supinate the hand, then we turn it palm up. If we pronate the hand, then we turn it palm down. These two terms are also used to refer to the entire body. If a person is lying face down, then they are prone. If they are lying face up, then they are supine. Dorsiflexion and plantar flexion refer to the foot. If we dorsiflex the foot, then that means we raise the toes up. If we plantar flex the foot, that means we stand up on our toes or point the toes down. Inversion and eversion refer also to the foot. If we stand up on the sides of our feet, then we have turned the sole of the foot toward the inside. That's called inversion. If you turn the sole of the foot to the outside, then that is eversion of the foot. Circumduction is the type of motion that we have at ball and socket joints so that we can move the arm or the leg in all three planes of space. We can even swing it around in a circle if we want to. So only the ball and socket joints, the shoulder and the hip, allow for circumduction. Rotation is for something to move in a circular fashion around a fixed axis. I mentioned the lateral rotator muscles, which insert on the head of the femur. When they contract, they roll the head of the femur inside the acetabulum, such as to rotate it. So what happens there, when they contract, they will actually turn the feet outward by moving the head of the femur inside the acetabulum. Excursion is a motion of the jaw. The jaw can laterally or medially undergo excursion. Those medial and lateral pterygoid muscles, which insert on the mandible, they will move the jaw left and right. It's part of chewing. So excursion is referring to a motion of the jawbone left and right. Protraction and retraction is referring to front and back motions of the jawbone. Okay, so those are just a few terms related to movements that are allowed at joints. All the joints have measured ranges of motions, and those are necessary things for clinicians to know. What is the normal range of motion? That gives you a way of knowing when a range of motion has been compromised, and therefore some therapy is needed to restore maximal range of motion to whatever joint might be injured. Okay, that's all I have for this show.